Health is one of my very, 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 very favorite topics. So it's amazing to me I struggled so much to put this slide presentation together. As I mentioned yesterday, this has become a much more important standard in the world of ACGME and family medicine. So one more thing we got to make sure our residents are showing competency in is social determinants of health. Okay, so we're going to talk about the what, the why, the how, and what I really got to is giving you guys some resources to do some follow-up. Should you decide that's something, well, you're going to have to if you have a program to get into, right? Because you guys at FQHCs, you know about social determinants of health. You live it every day, right? And you have programs that address it. And you've got some, as an example, in the state of Oregon, they've got a very robust population health and social determinants of health program going on through the Oregon PCA and at each of their clinics. So this is not a foreign topic to you. But where it gets more interesting, I mean, it's interesting already, but where it gets really interesting is how that intersects with residency training. All right, and how are we going to get our residents competent? All right, so breeze through this because you guys know this, right? Social determinants of health, it's not about when they're in your office getting, you know, a prescription or getting a diagnosis. It's all the rest of the stuff that exists in their world. This is a favorite, and it's an article that was done originally, I believe, in the 60s. The study was redone and published in 2001. And it says, if you haven't seen this, this is just a classic family medicine slide, right? In the average month, 1,000 adults, only one will be referred to the University Medical Center, right? You go back up a little bit, only 250 are consulting a physician. So that leaves 750 people who are out there with one or more illnesses or at risk for something. And they're just out there, right? It's a reason, historically, I used to show this slide because it drove the conversation of why ambulatory training matters, right? We don't just want to see the zebras. We don't just want to learn on the zebras. But now it drives a conversation of this is why social determinants of health is really important for residents to learn about, because folks are out there, all of them dealing with this kind of, you know, food insecurities and housing issues and job issues and family issues, right? Okay. Social determinants of health contribute to half of hospital readmissions. They cut, and here's another one that just came out, cut hospital admissions by nearly 30%. And that there's a call for action in medical education to address social determinants of health. I look at these, at our residents, as these sponges that are learning all kinds of other stuff, but are also able hands and bright thinkers to go raise the bar of what's going on in our communities, okay, by having very concrete, intentional curriculum on social determinants of health. Problem is there's not a ton out there, okay? And there's definitely no standardization of what that curriculum should look like. In fact, what we've got, at least in the literature at this point, is the training is sparse. It's very random. Some programs have it, some programs don't. It's highly variable, all right? Is our social determinants of health training that we do a lecture on community-based primary care and we have a health fair? No, but for some people that's it. Versus things like what you heard yesterday from Marianne McKenna, where their research projects are looking at data and geomapping it and saying, okay, how can we improve obesity over the course of time? Okay, now that's social determinants of health work, right? But as we talked about, it's required by ACGME in part because they found that the residents aren't equipped currently to deal with it out in their practices. And in my opinion, it is a field that is just burgeoning with opportunity for how to create training models and curriculum and learning opportunities that make a huge difference. All right, so how do we do this? I told you yesterday I'm about killing 2 birds with 1 stone, or maybe even many birds. I like to get, you know, I tell people I'm a single mom who managed to get through a PhD program by using 1 stone to kill as many things as possible. Okay. Those birds are kind of cute though. Okay, so what are our targets with this 1 stone? Scholarly activity requirements. We talked about that yesterday, right? 1 quality improvement and 1 other. And for me, this is the other. I mean, there's, sure, your residents could pick anything else, but why when you can do this fun stuff? As we mentioned, new requirements, faculty development. You know, how do we create a curriculum in social determinants of health when our faculty don't know how to do it themselves? Right? So we've got to develop our faculty in this. I look at that as that's a lot of fun, but I'm kind of strange that way. Hospital partner initiatives. How many of you have hospital partners who are looking at this for a host of reasons? It's because they've got an ACO model and they're trying to manage risk, or they're looking at you for their Medicaid risk population, or ED diversion, and they're sitting there going, we've got to deal with population health and social determinants of health. We really don't want our length of stay dropped by 50%, our admissions dropped by 50%, because we don't want our bottom line hurt, unless we're in a risk model. You know, so there's all kinds of schizophrenia going on, right? But how many of you have hospital partners that are saying we got to do, we're either are doing or trying to do something like this? Any of you? You do. Maybe, yeah. They probably do, and you probably don't know it. I can only think of 1 hospital system that I've talked with when I've talked about managing Medicaid risk populations, have said to me, we're not worried about that because we're not taking on any Medicaid risk. Okay. You show that you've got workforce that's being trained in this type of work. That's only a positive from the hospital perspective. Let alone the more warm and fuzzy community needs, right? This is what your community needs from you guys. Grant requirements I mentioned yesterday in Song Brown, they're going to want you to address this in your new program app. And it's just good health care. Now there are those who will say that FQHCs can't afford to do this because it doesn't generate revenue for them. It's a great way to hurt your bottom line. And that is one way to look at it. But let's go back to, you've got a workforce, you're training, and it's required. Okay. As was mentioned a number of times today, didactic learning is not the most effective way of teaching, right? But there are basics that we need to get across. And we expect to see them in the didactic schedule when ACGME comes by. Okay? So community-oriented primary care 101, community-based participatory research 101. Those are ones that I would definitely have in there. Research methods you want regardless of whether or not you're doing social determinants of health. How to manage your panel. How many of you have prepare going on in your clinics? 1. Okay. And there are folks who love it but hate how much time it takes, I think would be, and the interruption to staffing, the cost of staffing. I don't know what your take is, but it's got its challenges. What is that?
It's done.
True.
It's through our
Right. But physicians should still know what it is, right?
So I don't, it doesn't impact.
I gotcha. I gotcha.
But it's helpful because somebody else is
Right. And you get the information, right? Doing didactics with hands-on as far as using your EHR data to design your social determinants of health initiative. Okay, so that it's data-driven. And then large data set analysis. Those are just some of the off the top what can and does occur when you have a social determinants of health curriculum. When I get free rein in writing an application, I stick at least 2 community medicine rotations in it. And sometimes I do 2 plus a population health block. You're required in family medicine to have 1. And that one, you know, I'll be honest with you guys, and I hope, okay, the kind of traditional, we're not real into community medicine, so let's check the box. Curriculum is, okay, let's send them to the school health place, let's send them to public health, let's send them to the coroner. Who am I forgetting? It's good. Yeah, I mean, it's just,
Public health department.
yeah, yeah. It's really, I don't know. It checks the box.
Superficial.
Superficial. That's a good word. It's superficial. You've got a month minimum where you can light a fire if it's not already lit on social determinants of health and how to address them. And then the folks who are really into it, which usually are the FQHCs who are running their own program, say, okay, and we're going to do more. And that's when you can build a robust social determinants of health initiative. So up front, how are you going to build this curriculum? Now, when I start a program, we have a conversation about what is your niche? What is it that you're going to be about? Okay, because you're not going to be like every other residency program because you're you. Okay, but are you going to be an OB intensive residency program? Are you going to be a geriatrics intensive residency program? Are you going to be focusing a lot on inpatient, outpatient? You know, you've heard me talk about Ultimate a lot, in part because it's there in the room. But part of it, a lot of fun because of so much that they have in this area. Right? We could do some fun stuff. All right. I have a client right now where we built in a grant that we got awarded doing a community needs assessment. Now, the client is an FQ out of state. And the hospital's like, well, why do we need a community needs assessment? The hospital does them all the time. Okay, yes, and it's superficial. And it doesn't look at workforce, and it doesn't really look at social determinants of health and workforce. Okay, so we're gearing up to start that. And I'll tell you a little bit more about that one in a bit. Experiential learning, and I'll talk more about something I designed recently on that one. I'll stop because I'll get to that one. Experiential learning is something I absolutely have to be in the curriculum. Structured scholarly activity, faculty development, I mentioned that, and redesigning clinical cases to minimize structural competency. Now, what do I mean by that one? And I put in a definition there, structural competency. There is a group out of Northwestern that has started Social Determinants of Health and Medical Education Consortium. And they have put out some stuff out of New York, out of Einstein? I'm blanking on the med school, but out of New York, where they went and redid all of their medical school cases. And they had their med students do it. And in redoing the medical school cases, they're looking at any phrase, any word that implies a gender or a race or an ethnicity, so that you're not automatically assuming you know. You're not stereotyping up front, right? So it's not going to say Mr. Rodriguez, who is a homeless man, right? It's not going to say that. And they really have gone through thousands of cases and stripped them out. Now, I heard the creator of this initiative say that she did put a stop to it with the students when it got to them asking, why do we have it as the mom and dad? It should say the XX and the XX parents, or the XX and the XY parents. And she's like, okay. And she put a stop to it there, but I give it a couple of years and that one will be addressed as well, right? So topics like this, you're going to run, are integral to resident training, because if I'm not talking, as a physician, if I'm not talking in a way that is relatable to you, if I'm making implicit assumptions, and I'm creating a barrier to care. All right, so I'm going to give you 2 examples. This is one that I designed. There's a lot about opioid use disorder, right? Awful lot of ways to do of addressing this, ways to, what are we going to do about it? And we're required to have some experience, some learning activity in pain management for our residents. So have a community that said, this is a huge issue for us, so let's have our residents do some focused work on opioid use disorder. Well, I looked around, and although one of the leaders in this, Tim Munsing, brilliant man, wonderful, wonderful guy, willingly said, yes, I'll help. But they do a lot of didactics at his program. And I look around and everybody, it's didactics on opioid use disorder. And in the community that this is targeted at, they've got all kinds of other resources. Substance abuse and rehab organizations, a public health department that pulled together the physicians and got everybody Suboxone training. Okay. All kinds of resources for years. So why aren't we having our residents involved with that? Let's add that to the curriculum. Let's get them to the mental health organizations. Let's have them be with the police department. Just so happens that in that community, years ago, one of the biggest cases out there for a physician being arrested and losing their license because of inappropriate opioid dispensing, prescribing, was in their community. Okay, so one of the things Tim said is let's get the police department and the physicians and all together and have that conversation, right? And why wouldn't we have some of our residents, if not all of our residents, do Suboxone training? Particularly if we're thinking that we want them to stay in this community, which is why we started a training program. Okay. Now we're starting to get to how we're dealing with social determinants of health. We're not just picking opioid use because it's the flavor of the day. We're picking it because this community has a real issue with it. And this is the intervention we're designing. So not only are our residents trained in it to meet a requirement, check the box, but they can then go out and continue to make a difference. This is one I'm working on right now as well. This is in Oregon. I'll tell you it's in Oregon because it makes sense. When you look at social determinants of health, gender, and I'm no longer clear which is the right phrase for this because I hear different ones. I hear gender dysmorphia, I hear gender fluidity, I hear gendered identity. Gender expression. Okay. But Oregon was the first state that passed the law that driver's licenses are no longer binary. Okay. Happen to have a daughter goes to University of Oregon, so, you know, I kind of get this Oregon influence in my life. Okay. So it's not listed as one of the primary social determinants of health, right? But it doesn't take a rocket scientist to figure out that if I don't identify as she, her, hers, and my physician treats me like she, her, hers, there's a barrier to care, right? Yeah. Not seen the publications on that one yet. I think it's a whole area of future research and research growth. But again, it doesn't take a rocket science to figure out it's a barrier to care.
Research exists.
Is there? Okay. So we're developing the curriculum for the residents. Again, we're going to start with that community needs assessment. Because, you know, in my academic days, I was a community-based participatory researcher, which means community and researchers are hand in glove together. We design intervention together, all the way through publishing it together. And it means I don't know, my PhD is no different than your PhD in the street, your PhD in your community. You know this better than I do. Okay? So it is presumptuous for me to even begin to think that I know what the issues are in this community. Hence the community needs assessment. You tell us, what are the issues? What are the issues with gender expression when you are seeing your physician? Talk to us about that, right? From there, we will design the didactic, the experiment, the experiential. We'll look at what cases exist, and there is an academic institution involved there, so it's going to be interesting to see how much they'll take this on. But what changes in case studies will we do? Or will we develop some new case studies so that our residents, and who knows, maybe some medical students, will get the opportunity to apply this perspective to the clinical cases. Of course, then you go back to faculty development. Got to have faculty to know this to do this. And I did not spell curriculum right. Evaluation of curriculum and publication. Okay? Right? You want to let people know what you're doing. So, again, this is such a broad field. It's like how to get this to something useful for you. And what I got to was, let's give you some resources. First is a practical playbook. Practical playbook was developed by a group headed up by a gentleman named Lloyd Mitchner. Lloyd is the chair emeritus of Duke Family Medicine. I've had the distinct privilege of getting to co-present with Lloyd on this topic of, he talks about large data sets analysis, and making impacts in your community based on that large data set analysis. And a lot of that is in the practical playbook. You can get it on Amazon. And then I go to a place of, and how are we changing our residency programs so that we're not just throwing up yet another silo, we're not just starting yet another residency program because you want one, but we're starting it based on what your community needs and wants to address the health care, the social determinants of health of your community. Okay. Folks who know me know I'm all over the country setting up residency programs all the freaking time. I can do it with my eyes closed. It's yet another silo. It's yet another, Veruca Saltz from Willy Wonka going, but I want one. Okay, everybody wants one. But how is yours going to be different? How is it going to change the world? It's a practical playbook. Robert Graham Center, we mentioned that yesterday to you guys. They actually have a curriculum, population health curriculum. Okay. and I've got the 2 pages there, but you can actually go on, click on, and get different case studies. So this doesn't have to be horrifically hard. Those of you who are starting residency programs, you know, who have your accreditation, I'm looking at 2 of you right now because Renita just stepped out. This doesn't have to be horrifically hard. You don't have to change the world with your first go around. But start, okay? And this is a wonderful place to start. This is Robert Wood Johnson Foundation. Love this group. This is the group I just mentioned out of Northwestern. A lot of their work is at med school level. They actually have different articles and summaries of research and cases and things like that online. And what's interesting is how many are not by MDs, but more by PAs, NPs, and the like. So that's got to change, right? You've got to get more from a whole diversity of health professionals. They just did their first conference a couple months ago. So they are young, but this thing I believe is going to catch on. This is where it's going to happen, where we see how we work, how we integrate social determinants of health and education together. It was Marianne, was it Marianne? No, it was Candace yesterday who mentioned Authority Health and their population health certification program. Okay, so this is a group that's done it, done what we're talking about. Now they've taken it to a whole level of saying, and you walk away with a certificate. You know, and there's some pros and cons to that. You know, there's some pros and cons to that, to actually getting a certificate. I don't think that's necessarily required at this, by anybody at this point, but it's cool. Right? And then it's not complete unless we talk about New York and specifically Montefiore. Montefiore has been doing social determinants of health work probably 20 years. They have been on the forefront of this, and in the state of New York, they published this document on training primary care residents on social determinants of health. What I don't particularly like about the document is it's like, these are kind of the didactic topics you would cover. This is the didactic information, but it doesn't get into the experiential. It doesn't get into design, to actually doing that research project where you would address the social determinants of health. But you have to have time in your curriculum to allow for a research project like that to be done. You know, that's not a project you can do in a week or 2 weeks or even in 1 month rotation. That is a longitudinal project. That is a project that maybe is done in a group and people come in and out of the group over time, and the project continues and continues and continues. And that's it. I'm pretty short on this one. Nellie's giving me the eye. Okay.